Everyone, thank you for being here, and I'm calling this oversight hearing to order. And before we get started, I'd like to ask for unanimous consent that Ms. Houlihan join us today on the dais.
Absolutely.
Without objection, so moved. I want to welcome everybody to the subcommittee on the Health's second hearing of the 116th Congress. Today is a historic day in this committee, as it marks the first time in recent memory that this committee has held a hearing singularly focused on serving our nation's 2 million living women veterans. Women have served in every American conflict since the Revolutionary War. Deborah Sampson and Margaret Corbin, the first American women known to have served in combat, earned pensions for their service during the Revolutionary War. Today, 2 million women veterans live in the United States and are the fastest growing demographic in both the military and veteran population. Currently, women comprise nearly 20% of military personnel and 10% of the veteran population, and 35% of whom are women of color. Even though women have served in every American conflict, the Department of Veterans Affairs is a system created to serve men and did not serve women veterans until the 1980s. While the Department of Veterans Affairs has indeed evolved, and some say that the organization is not your grandfather's VA, but there is still a long way to go. That is why the Women's Veteran Task Force has been created to ensure there is equitable access to all VA services for our nation's women's veterans. And I will add that I'm encouraged that the VA and the Secretary himself has committed to working with us to that end. However, despite centuries of honorable service, the women who serve our country are still treated as second-class service members and veterans. A visible minority in the military, women experience every day indignities that make them feel like they do not belong. The probable root causes range from the impacts of the long-standing prohibition on women in combat jobs to going into combat-wearing protective equipment that was made for men. Most troubling is the widespread incidence of sexual violence in the ranks, an epidemic that disproportionately affects women. At least 1 in 4 servicewomen experience military sexual trauma by the very teammates who are supposed to have their backs. More than half of service members who report their assaults also report that their commands retaliated against them. Therefore, it should not be surprising that when women leave the military, they are reluctant to enter veteran serving spaces. When they do, they often find the same lack of respect that they endured on active duty. Recent research found that at least 25% of women veterans experience sexual harassment or questioning of service status by male veterans while at the VA. Even the organizations meant to serve veterans are often hostile to women veterans. In her statement for the record, Army veteran Melissa Bryant, Chief Policy Officer of Iraq and Afghanistan Veterans of America, explained, "Now, as a veterans advocate, I still hear the misogyny in our community from the time I'm asked who is your sponsor at VA medical centers to when I'm referred to as young lady by my own veteran colleagues." VA system itself remains rife with barriers to care. 24% of women veterans using VA health care still do not have a specially trained women's health primary care provider. Women veterans are 46% more likely to use community care than male veterans, largely to receive basic preventive services such as pap smears and mammograms. This has resulted in billing problems which again disproportionately affect women. In addition, women veterans face longer wait times, staffing shortages, and facilities that fail to meet basic environment of care standards. Even here in Washington, D.C., the Women's Health Center has more limited hours available for primary care appointments than are available for men. Women veterans are remarkable Americans and deserve equitable access to the benefits and resources that they have earned. Women demonstrate resilient leadership in their communities and classrooms, in their careers, and right here in Congress. In short, our goal is to make the invisible woman veteran visible. So as chair of this subcommittee and the Women Veterans Task Force, I am well aware of the work we need to do, and today is our first step in doing it. So with that, I would like to recognize Ranking Member Dunn for 5 minutes for an opening remarks he may wish to make.
Thank you very much, Chairwoman Brownlee, and thank you for having this hearing. Today's hearing is just the start of an ongoing conversation I expect this subcommittee to have throughout the 116th Congress. So in the interest of time and given the constraints we're under this morning, I will keep my comments brief and to the point. I appreciate the opportunity to be here to discuss how to break down the barriers for women veterans in the Department of Veterans Affairs system-wide. Women are a sizable and growing segment of the VA's patient population, as you noted, with the number of women who use the VA healthcare system tripling in just the last 18 years. VA has made a number of strides to address the unique and often complex needs of women veterans. However, far too many disparities continue to exist in care, benefits, services, and treatment. I'm particularly distressed to have learned that according to a recent study, 1 in 4 women veterans report being subjected to inappropriate, unwanted comments from male veterans in the VA system. That's unacceptable. I look forward to this morning what steps we're going to be taking to eradicate this type of harassment in the VA enterprise-wide and to ensure the equitable treatment of women veterans within the VA's environment. So thank you again for calling this important hearing, and I yield back to you, Chairwoman Brownlee.
Thank you, Dr. Dunn, and thank you to our witnesses for being here today. We have 2 extraordinary panels joining us today. For the first panel, we have a formation of all women veterans. First, we have Ms. Joy Elam, National Legislative Director of Disabled American Veterans. Next, we have Ms. Lindsay Church, Chief Executive Officer of Minority Veterans of America. Next, we have Ms. Ginger Miller, Chief Executive Officer of Women Veterans Interactive. Next, we have Ms. Bridget McCoy, Chief Executive Officer of Women Veterans Social Justice Network. And finally, we have Captain Lori Manning, Director of Government Relations for Service Women's Action Network. With that, I now recognize Ms. Elam for 5 minutes. Welcome.
Chairwoman Brownlee, Ranking Member Dunn, and members of the subcommittee, thank you for inviting DAV to testify today. As a service-disabled veteran who has gotten my care at VA for more than 2 decades, I appreciate the opportunity to discuss cultural barriers impacting women veterans' access to health care. There is no bigger barrier to care than a culture that does not embrace women veterans or, at best, makes them feel marginalized. Ensuring that women veterans are treated with dignity and respect, have equal access to high-quality comprehensive care and readjustment services from VA is a top legislative priority for DAV. The number of women coming to VA for care has tripled, as you've all noted, since 2000, and many have wartime service, and more than half of the women using VA healthcare system have a service-related injury and will need a lifetime of care. While VA has made progress and illustrated a commitment to improving services for women veterans, several longstanding challenges still remain. DAV's most recent report, issued in 2018, Women Veterans, The Journey Ahead, highlighted the need for culture change in VA. We found that women veterans perceived their military service was not understood or appreciated like their male peers. Women veterans told us they want to be treated with dignity, respect, have equal access to earned benefits, and most importantly, they want to be recognized as veterans and appreciated for their contributions in military service. Another notable barrier to care is that many women veterans do not feel welcome or safe at VA facilities, as confirmed by the recent study just mentioned, that 1 in 4 women reported being harassed by male veteran patients. Unfortunately, women who experienced this harassment were significantly more likely to report either delaying or missing care. We applaud VA's new End Harassment campaign and training of employees that's underway to intervene when they see harassment occurring, and encouraging veterans to immediately report such conduct. To meet the goal of a zero-tolerance policy for harassment, we challenge all veterans and veteran service organizations to do their part as well. Women veterans who have their military service questioned, who are routinely disrespected, and will not stay to find out that VA offers exceptional, evidence-based, and culturally competent clinical care and integrated services. And women veterans need that expertise, and they deserve to have a system that fully embraces and supports them. VA researchers have been specifically looking at barriers to care for this population, as well as health impacts of wartime service, and the unique transition issues women face when they return home. These concerns are heightened for women who make greater use of community care than their male peers, and who have experienced a variety of problems under the CHOICE program. As VA transitions to its new community care network, it will be essential that community providers are properly trained about veteran culture, common military exposures and health conditions for women, and receive training and evidence-based practices for treating them. VA healthcare is the best system of care for women veterans with complex healthcare needs. VA's veteran-focused research, comprehensive health and mental health services, and specialized programs for trauma make it uniquely suited to care for this population. But longstanding issues that persist act as barriers to that care for some women. VA still struggles at certain locations to ensure privacy, safety, a welcoming environment, all noted, and sufficient numbers of staff with expertise in women's health and specialty care coordinators, women peer specialists, and dedicated women's clinics. To address these persistent challenges, it will require the Secretary to commit to cultural transformation at all levels of the organization and to dedicate the necessary resources to achieve that change. This means keeping the needs of women veterans central to planning and decision-making in all program offices. In closing, we're pleased with the progress VA has made, but there is so much more to do. We do, however, want to recognize the exceptional work of the Women's Health Services Office, the Center for Women Veterans, and the Veterans Experience Office, which we are pleased to learn are listening and collaborating with women veterans to build trust and improve their healthcare experience so they can count on VA for providing access to quality, timely care at all sites. Again, Madam Chairwoman, we thank you and the subcommittee for your continued interest in improving the health services for our nation's women veterans, and I'll look forward to responding to any questions you may have. Thank you.
Thank you, Ms. Elam, and I now call on Ms. Church for 5 minutes.
Chairwoman Brownlee, Ranking Member Dunn, and distinguished members of the committee, thank you for the opportunity to testify today about the cultural barriers impacting women veterans' access to health care. I would like to begin by acknowledging that the land on which we gather is the unceded territory of the Piscataway and Nacotchtank people. My name is Lindsay Church, and I am the CEO and co-founder of the Minority Veterans of America. I served in the United States Navy from 2008 to 2012 as a Persian Farsi linguist. I am a queer, gender nonconforming woman veteran that served all but 3 months under Don't Ask, Don't Tell. I was medically retired after 3 surgeries to my sternum and ribcage left me permanently disabled, and I personally received my care at the VA. As the CEO of MVA, I represent veterans across 46 states, 2 territories, and 3 countries. 47% of them are women, and several of whom are in the audience today. Together, our members account for over 6,000 years of service, some dating back to conflicts and eras that predate when they were legally recognized as veterans, my mom being one of them. In today's military, the role of women is quickly expanding, and though more jobs and occupations are opening up to women every day, the culture and institutions meant to support women veterans after service has not kept up with the rapid growth. Similar to our male counterparts, we as women veterans are immensely proud of our service and what we have done to the service we have and support we have offered to our nation. However, many of us experienced instances of harassment, degradation, and discrimination based on our gender identities and/or sexual orientations. We withstood and persevered those experiences, and we did so honorably. The harassment that happens to women in the service is magnified by the weight of the entire United States military that renders each of us powerless until the day that we separate. Even if we want to leave out of fear for our own safety, we are beholden to a system that demands compliance no matter the circumstances. Upon discharge, we must decide, based on the severity of our experiences and the intensity of our needs, whether or not we will return to a setting where military affiliation is the common thread among the community. This is the dilemma that each of us faces when we are deciding whether or not to enroll in the VA. For many women, voluntarily re-entering military culture to use their VA benefits is an insurmountable barrier. Moreover, the VA has a poor reputation. Among our community, we know them for perpetuating a toxic culture for women and minorities, providing subpar care that lacks a nuanced understanding of who we are, and seemingly every day there's a new story of a veteran dying by suicide in the VA parking lots and waiting rooms. For those of us that finally overcome these barriers, we enter VA facilities across the nation only to be met with plaques inscribed with the words, "To care for him who shall have borne the battle, and for his widow and his orphan." Lincoln's words, which are the motto and mission of the Department of Veterans Affairs, serve as physical representations of the deep and lasting history of invisibility for women in the military and veteran community. Changing the motto won't by itself address the deep cultural divide that exists between women and the veteran community, but it is a step in the direction toward inclusion. Continuing to maintain and uphold the motto, despite that women veterans have called for change, signals a willful desire to exclude us. Chairwoman Brownlee, Ranking Member Dunn, and members of the committee, if we are to change the outcomes that women veterans are experiencing today and increase their access to health care, we must look to the roots of the problems and not just triage the results. First and foremost, this starts by opening a dialogue about the inclusion of all service members in the VA's motto. Second, accessing the VA needs to be easier. We want an opt-out rather than opt-in process, not just for women, for all veterans. If we believe that veterans have earned their benefits, service members should automatically be enrolled in VA benefits and rated for their service-connected disabilities before they are discharged without relying on outside agencies to file their claims. Additionally, women veterans should be assigned a primary care doctor in the nearest women's clinic. Third, women veterans need to have greater access to positions of leadership at the VA. Representation matters, and if we are not represented in the places where decisions are being made about our health care and our benefits, how can we ensure that we are heard, considered fully, and that our ideas are acted upon in the same way as our male counterparts? Lastly, all VA facilities should have community standards and expectations of staff and patrons. Stories of women veterans being sexually assaulted, harassed, discriminated at VA facilities should be anomalies and not commonplace. Thank you for your time and consideration on this matter. I look forward to your questions.
Thank you, Ms. Church, and I now recognize Ms. Miller for 5 minutes.
Chairman Brownlee and the members. Chairman Brownlee and members of the subcommittee, as the president of and CEO of the national nonprofit organization Women Veterans Interactive, I am grateful to present my testimony regarding the cultural barriers impacting women veterans' access to health care. To understand the cultural barriers impacting women veterans' access to health care, one must first understand the climate in which we exist. The women veterans climate, a hostile takeover. Women veterans are trying to stay afloat in a culture that has been male-dominated for centuries, and now we are competing to stay relevant in a culture that insists we downgrade our service to run parallel with that of a commitment made by a military spouse to her husband. Women veterans are uniquely different from military spouses, and it's time that this country stops lumping us together, not to mention being overshadowed by the caregivers. Women veterans are existing in a climate where we have become good for business, but not good enough to do business with. And even more unfortunate, women veterans are living in a culture where our voices are only heard in a celebratory fashion when we achieve something great or when we hit rock bottom and become good for press. I'm here to testify this morning in an effort to change the climate and culture that has become the norm for women veterans. Our noble service to this country is worth more than a story. Our sacrifices as women veterans are worth more than a tick mark on an outdated, one-sided survey conducted by male-dominated VSOs who may happen to have a few women veterans on staff. Women veterans are more than objects. And we don't need another survey. We need action. We don't need another national portrait campaign. We need a national outreach and engagement campaign. Women veterans don't need another male-dominated VSO to represent us at the table. We need to have a seat at the table. And if we can't have a seat at the table, we will continue to build our own. For women veterans, the environment in which we are expected to thrive in after serving in the military has become hostile and at times volatile, to say the least, because our voices are not being heard appropriately, and we do not have accurate representation at every level of government. Women veteran nonprofit organizations are grossly overlooked and underfunded, if funded at all. Our volunteers are overworked, and for some, the outlook is bleak. And yet we continue to hold on and hope against hope. Hope for inclusion, to have a seat at the table where our voices will be heard, and hope for much-needed funding to deliver the proper services to the population we serve. Women Veterans Interactive is a solutions-driven nonprofit organization focused on outreach and engagement. WVI delivers impact in the lives of women veterans through a holistic, proactive approach that is grassroots in nature. The mission of Women Veterans Interactive is to meet women veterans at their points of need through advocacy, empowerment, interaction, outreach, and unification, all to break down barriers that lead to homelessness. WVI addresses the unique needs and unrecognized challenges faced by our nation's 2 million women veterans. Since inception, Women Veterans Interactive has supported over 3,500 women veterans, and our network has grown past 50,000. Women Veterans Interactive and the Department of Veterans Affairs have an intimate understanding of the importance of women veterans becoming connected to healthcare. Since 2012, WVI has invited the Department of Veterans Affairs into our fold to collaborate with us on all of our outreach efforts. Most recently, WVI's 2018 and 2017 Annual Women Veterans Leadership and Diversity Conference, we had a benefits claims clinic in collaboration with the Department of Veterans Affairs, in which each clinic had approximately 150 veterans to attend. The feedback from the benefits claims clinic have been remarkable, with some women veterans stating that it is the first time the VA has treated them like their service matters. And other women veterans said they have a brighter outlook on going to the VA Medical Center to receive health care. Additionally, in 2017, WVI partnered with the Center for Minority Veterans to conduct a virtual town hall with over 300 attendees. In 2016, we created the State of Women Veterans social media campaign with a goal to reach 500,000 veterans, and we surpassed that goal. Every Women Veterans Interactive and Department of Veterans Affairs collaboration is positive. So I pose the question, why is more not being done by the Department of Veterans Affairs to collaborate with women veteran nonprofit organizations like Women Veterans Interactive? And why are more women veterans organizations not invited to the Veterans Affairs meetings, especially when it comes to discussing issues and solutions around women veterans? If we're going to change the culture, and if we're going to have women veterans to have more access to health care, then, Madam Chairwoman, we need to be at the table. I'm recommending that we work together to find solutions and have something where we can allocate funding for collaborative women veteran direct outreach engagement with the Department of Veterans Affairs, and require the Department of Veterans Affairs to focus on consistent outreach with women veterans and meet with the Secretary of Department of Veterans Affairs on a biannual basis. Thank you, Madam Chairwoman.
Thank you to the House Committee and Committee Chair. Thank you for inviting my organization and the inclusion of my testimony on issues concerning women veterans, specifically the cultural issues impacting women veterans. You'll see in the notes I sent a document that has all of the information related to the organization that I founded 10 years ago, Women Veterans Social Justice Network, as a homeless veteran in HUD-based housing during my process with disability process in the VA. So I am an ally. I am a military sexual trauma MST survivor and advocate. My service and contributions are as important as my male veteran counterparts. Women veterans serve, yet our visibility and opportunities have unseen barriers to accessing many of the programs that the civilian sector believes are available to all who served. It is vitally important to hold in high regard and utilize the narratives of veteran women like me of all eras and all service periods and all service backgrounds as primary sources to inform research, curriculum, and policies concerning women veterans. The cultural issues impacting women veterans are vast. There are too many to fully note in this setting to give the full historical context, legislative background, and full unintended consequences and implications of each. I do believe that the historical context of women not being formally included in the military structure until the 1940s is a topic for inclusion in this hearing. Women veterans were not legislated to use the VA for gender-specific medical care until the early 1990s. Only in recent years have women-specific health care spaces been constructed in VA facilities. In my work over the past 10 years and my personal experience interacting with the government and the community for support, a major factor that repeatedly and consistently challenged me has been the language which is used to describe and talk about me as a woman veteran. Within the context of being a woman veteran, I've heard terms like low-hanging fruit, female, victim, and references by men about how easy it is for a woman to get disability benefits. And I assure you that that is categorically untrue. These othering terms have an unintended consequence for our country and the communities that serve women veterans. How we speak about women veterans can be a part of a deeper problem of what we believe and have been socialized to believe about women in general. This is a root cause factor that drives the cultural divisions and creates a barrier for meaningful, well-funded support for women. The language used to speak about research, legislate, create, and institute programs for our women veteran community continues to be a major limiting factor toward addressing issues and needs. Why are organizational leaders calling us female after the military service? There are no female veteran organizations. Where is the National Female Veteran of American organization? Even in 1948, when President Truman signed the Armed Services Integration Act, female was not used in the title, but the word women. I know that there will be some that say that doesn't matter, but I will argue that using biological terms to dehumanize what you name or call something or the language you use to speak about a person does have impact positively or negatively. We can trace the language in policies and legislation and funding and see that funding drives programs and services. Second, women veterans currently have narrowly defined, language-specific access to some of the most well-funded and highly engaged programs. Most are intentionally excluding a huge proportion of women, and the funding legislated for their programs is language-specific to eras, combat, and gender. It is emotionally draining as an advocate to continually send women to organizations that have veteran programs to have them told that they don't meet the guidelines. Further, the brochures are male-centered, and the veteran service community organizations and their organizing documents do not include women who have served, or they are told to go to auxiliary membership or put together with spouses, which is completely different population. Third, VA medical treatment visits pose issues when organizing documents and play cards have male-centered quotes and presentations. The space was not created with women in mind. There have been upgrades and changes in support of women in the facilities, but we are still being catcalled and harassed going into the mental health and medical appointments when we can get them. It is never clear what the outcome will be for women who reports harassment or for the patient or employee that harasses. My personal experiences of being harassed within the VA and the discussions with other women about the need to change their appearance come to certain times of day, switch to other hospitals, or stop going to the VA at all is another area of discussion. We're not always treated with the same professional respect as our male counterparts. Many times our rank and era in service are used to limit access to programs for professional advancement. I have more, but I know that my time is winding down, and so I want to hand over the time to my colleague here. Thank you.
Thank you, Ms. McCoy, and I now recognize Captain Morgan.
Chairman Brownlee, Ranking Member Dunn, distinguished members of the subcommittee. On behalf of the Women's Service Action Network, I thank you for the opportunity to share our views, recommendations regarding the cultural barriers to women veterans' access to health care at the Department of Veterans Affairs. In the past years, VA has made hard-won improvements to the quality and comprehensiveness of women's care, but all that improvement is for naught if women encounter barriers when trying to use that care. I'll discuss two of these barriers today: sexual harassment and the invisibility of women veterans. Over the years, we at SWAN have heard many complaints about groups of male veterans getting together to harass women veterans on VA grounds, including at the Washington, D.C. VA hospital. An academic study and a newspaper article, both published this year, elucidate the problem. The study appears in the Women's Health Issues, published by the Jacobs Institute of Women's Health. The article by reporter Jennifer Steinhauer was in the March 12th edition of the New York Times and headlined, quote, "Treated like a piece of meat, female veterans endure harassment at the VA. The study sampled women veterans who used 12 different VA hospitals and found 1 in 4 of those sampled reported receiving catcalls, derogatory comments, propositions, and denigrations of the women's status as veterans from male veterans on the grounds. The New York Times article recounts how, quote, an entrenched sexist culture at many veterans' hospitals is driving away female veterans, unquote. Swan believes that what women veterans want and warrant is for VA leaders at all levels, with oversight from Congress, to stop that harassment now and to create a VA culture in which women veterans are treated with the same respect, appreciation, and dignity as male veterans. Women veterans also report to Swan that they feel invisible in the office staffs of VA facilities and to the American public in general. And they are. It begins with the VA motto: to care for him who has borne the battle, his witness, and his orphan. Swan, while appreciating Lincoln's historic words, is among the veterans organizations which support changing that motto. According to the Department of Veterans Affairs' February 2017 report, the past, present, and future of women veterans, only 22.4% of all women veterans use VA health care, making them a mere 7.5% of total VA health care users. Women veterans are irked when they are asked for their husband's Social Security numbers at check-in desks, or are refused free coffee provided at some VA facilities with the admonition that the coffee is only for veterans. These slights seem minor, but they accrete over time, leaving women veterans frustrated and disheartened. The invisibility becomes more damaging when the gender-specific needs of women veterans are ignored, as happens, for example, when they are sometimes issued prosthetic devices designed for men. This should never happen. And major damage can be done if women veterans are invisible to those at any level making tough decisions on healthcare resources, if those decision makers either don't understand the need for women's programs or conclude that reallocation from these programs helps many while hurting only a few. Swan believes leadership at all levels must take great care when initially allocating or later reprogramming resources to or from women's healthcare programs, that they have a clear understanding of the effects their actions can have. Swan additionally entreats Congress to exercise its oversight responsibilities to ensure the needs of women veterans and other special focused populations are not unduly sacrificed when such actions are necessary at the national level. Madam Chairman, let me say how deeply I appreciate the opportunity to offer Swan's views on these critically important matters. Thank you for your time and attention.
And I thank you for your testimony, and I thank all of the witnesses here today for their testimony. To me, it sounds like we're having a veteran women Me Too moment that I think all of us collectively have to make into a movement. So I think we're in the beginning steps of that. So we will now begin the question portion of the hearing, and I will recognize myself for 5 minutes. And the first question that I wanted to ask Ms. Elam from DAV is, you talked about in your testimony with regards to solutions to some of these issues, is to make women's health a standalone program, leadership with its own leadership structure at the central office, et cetera. I know in talking to some of the medical center directors who get allocated a large chunk of money, and it's their responsibility then to allocate it to as they see fit in terms of what their needs are. And I believe that in some situations, women's needs are being overlooked across the country. But if you could just speak a little bit to how you think things should be restructured.
Well, I think that a task force would help in terms of internally within VA. I mean, we're hoping that the Secretary will really take this to heart. I mean, he's indicated that he wants to ensure women veterans receive the care and benefits they deserve through VA. These programs, I think you're exactly right, have been ignored because of the funding structure. They're often lumped in, they're via allocation with, primary care. We've seen report after report from the IG or GAO about these same problems. I mean, I could look back at testimony or those reports over the years, and we see the continued same problems. They don't get resolved. So I think it's going to take a different tact, and I hope that VA, the secretary from the leadership down, will determine what would be, convene a task force, determine from the leadership at the VISN level, at the local level, how can they best serve to make sure they really get at these problems.
Thank you. And Ms. Church, I thank you for your testimony, and I think you were very clear in saying that women veterans are more likely to be a member of an ethnic or racial minority, the LGBTQ community, or the like, than our male veterans. I think the data shows that if you are a minority, if you are part of the LGBT community, that actually the services rendered are even less than women overall. You also talked about using the traditional VSO for accessing compensation and benefits, and you described them as insurmountable barriers for women veterans. What needs to be done there?
Honestly, in order to be able to access your benefits, you should be able to do it automatically through the VA or through the Department of Defense. We've gone to a place where we use a third party to file our benefits and our claims. However, it should be automatic. It should be something that happens right when you get out of the service. As a medical retiree, I was part of a pilot program in 2012 of I was one of the first to get a DA or a DOD disability rating as well as a VA rating as soon as I got out. So as soon as I got out, I knew exactly what my benefits were going to be. I already had my service-connected disabilities, and I was able to carry on with my life. I didn't have to use a traditional VSO, and I didn't have to be re-traumatized, because some of these places can be the biggest perpetuators of toxic culture. It has happened for years and years, but at the end of the day, we shouldn't have to go to a third party in order to get access to our benefits through the government that we work for. So my recommendation is remove the third party.
Great. And when you exited the military, was it clear what you needed to do to receive your services?
Absolutely. You're actually able to, if your unit allows you to apply for VA benefits 6 months before you're out. However, it's not a mandate. It should be a mandate that you go 6 months before you're out, that you go and get your disability rating.
Thank you. Ms. Miller and Ms. McCoy, you both have served our country honorably, and in both of your testimonies, you've talked about your homelessness, and certainly, I think all of us here on the dais believe that no one who wore the cloth of our nation should be without a home, and women veterans are the fastest growing homeless population in our country. So if you could just describe a little bit what the economic stability, how the economic stability is a factor in enabling women veterans to access their own health care.
Thank you for that question. From where I sit, the economic status has something to do with it, but it's really the outreach to women veterans when they get out of the military, because they're disconnecting from service, and they're disconnecting from their peers. As for me, when I became homeless in the early 90s, my husband was suffering from post-traumatic stress disorder. I got a medical discharge. We stayed with family for an X amount of time. Then when his post-traumatic stress disorder kicked into high gear, we had to find some place to go. I was unskilled. My son was about 2 years old at the time. I didn't have a college degree. So I think for women veterans to get connected and stay connected to the source, then that will also help to prevent the homelessness. The economic status has a little bit to do with it. One of the things we do at Women Veterans Interactive, if a woman veteran is homeless or on the brink of being homeless, and she has a claim in with the Department of Veterans Affairs, we can get that claim expedited. We've stopped at least 2 to 3 evictions in 2018. If a woman veteran was getting evicted, we would call the Department of Veterans Affairs, they would expedite the claim. So I think there's just like a major disconnect when it comes to the economic status of homeless women veterans.
Thank you. Ms. McCoy, briefly, because I'm way over my time, which the chair is not supposed to do.
So yes, it is economic. In my case, I came out of the military. I didn't understand that the benefits, that I needed to keep fighting for my benefits. I was considered service-connected right out of the military at 0%. I was a single mom with a very disabled daughter, and I had medical conditions that were already there but untreated. And so in that process, I'd had some education after I got out. I did all of the things I thought were the right things and still ended up homeless. And so it is an economic issue. In my case, it was an economic issue. But it also has to do with what Ms. Ginger Bain said. It's the disconnect. And so in my case, that's why I created WVSJ. We started online as a community peer-supported network, supporting one another online, just with information resources, and through that process grew to over 12,000 followers on Facebook with over 50 networks worldwide. So it's very important to get information and resources out to women, but also the challenge with homelessness is that it keeps changing. Every year, what is homelessness keeps changing. So when I was experiencing homelessness, couch surfing was considered, and now it's not. So we have to, again, language is a big part of it.
My time is up, but thank you very much. I now call on Dr. Dunn for 5 minutes.
Thank you very much, Chairwoman Brownlee, and thank all the members of the panel for your compelling testimony. Appreciate that. This is a question. Let me just start on the right end of the panel and sort of work over. Given some of the barriers to care within the VA healthcare system and the other portions of the VA system, which all of you have referenced, and the fact that it can take a long time to change a culture like the culture in the VA, would you support granting women veterans greater authority to use VA healthcare benefits in the community to ensure they have access to care? And I'll start, Mr. Lem, if you will start. Lem, I'm sorry. Start.
Thank you for the question. In my testimony, one of the things that I point out is that women veterans do use higher rates of community care in VA, through VA being referred to the community because of their lack of ability to provide maternity care and some other specialty services that they don't always have a provider available for.
Yeah, so for specialty services, clearly, but I was thinking more the routine.
Right. So the issue that I bring up in our testimony is that VA has done so much research on women veterans, and the women veterans who are coming to VA are very clinically complex and users of a high number of services across the board in both primary care, specialty care, mental health. And we're just concerned that fragmentation of care can relate to gaps in care for them, and we want to make sure that providers in the community have the expertise to treat them. Well, we want women to get the care they need and what's best for them, and that may be the situation they prefer or want or need, but we need to make sure that the women providers or the providers that they're going to, that they're going to get quality care with expertise in the conditions and having an understanding of what exposures women have, experienced and what are the most conditions that they're being treated for.
And maybe quickly down the same question about access to care in the community. I mean, we assume in the community presumably they've solved these issues, or they'd be out of business. Go ahead.
So I hear your question, and I would like to actually say that I prefer that the VA step up first. I believe that we have a lot of work to do and that there are a lot of actionable items for us to continue to build the outreach and build the reputation up of the VA first. I do believe that we're going to see women will experience barriers, whether it be civilian care or VA. In the civilian, they will lack understanding of what it means to be a service member. In the VA, they will lack understanding what it means to be a woman. However, breaking apart the VA doesn't necessarily accomplish that.
As a veteran, I certainly agree with you on that. And just we're working our way across. So access to care in the community as a potential stopgap maneuver.
Well, I think that would be an awesome option because the VA has been researching women veterans for years. We're not aliens, we're women. There are plenty of doctors out in the private sector that support and service women every day. So, while you're trying to figure this thing out, I would like to have an option to go get my pap smear and to get my mammogram with a provider that I'm used to when I had my private care. I mean, why should we have to suffer and walk through the halls and be catcalled and all of these things while you figure it out? I would love to get a voucher to go out to a private sector, to a private doctor to get my health care, especially my women's health care, because I know that if one thing or another, at least they're certified. They're real doctors.
Thank you. And
In my case, I spend tens of thousands of dollars outside of the VA on my own care because there are so many different areas of gaps in services. I agree with Ms. Lindsay and Ms. Ginger because I think both parts are equally as strong. We don't need to just let the VA just walk away and say they don't have to do anything. They need to hold up their part of the bargain. But I also feel like while we're waiting on that process, we do need services in place. I would love to have a voucher to pay for my chiropractic. I would love to have a voucher to pay for my acupuncture because these are things that are coming out of my pocket. So it's very important to have these types of services and resources.
thank you, Captain.
I'd like to signal a little bit different notice. I mean, I live in the Washington, D.C. area and get most of my health care on the outside because I'm a military retiree and I have no service disconnection. It's not that easy to get appointments on the outside, particularly for some of the specialty things. Want to see a dermatologist? Call me in 3 months. I also think that it is necessary as a stopgap sometimes, but I worry about, particularly if you address women as a group and send them outside, that VA will at some point down the road think that we don't have to be responsible for them anymore. It's just the guys we're really taking care of now.
I appreciate your insights on that. As you can tell, the way everybody evacuated, the votes have been called across the street.
So are you taking over the meeting?
We'll be back. We can come back there.
I'm just teasing you. I wanted everybody to know that members are getting up because we need to go and vote on the floor, so we will pause momentarily. I anticipate it will probably be at least a half an hour. It could be a little bit longer than that. And what?
You'll need to recess.
Okay. Excuse me, the terminology is we will recess. But we will reconvene. Is that the appropriate word? Excellent. So thank you very much for being here, and we will join you shortly.
Thank you.
Thank you.
We'll recess, but we're not
Thank you, everyone, for waiting. We had quite a few votes on the floor, so I deeply apologize, and I'm afraid that some members who are needing to get back to their districts because we're not going to be voting again today might not be returning to the committee. We'll see how it goes. But we are reconvening, and I am gaveling back in. And Mr. Mercer, you have 5 minutes, and thank you for sitting in as the ranking member.
Well, thank you, Chairwoman, very much. It is my honor to be here with you all, and thank you all for waiting as well. I'm in Pennsylvania's 9th Congressional. We have a Veterans Administration in VA in Lebanon, which tends to be ranked very well, and we're pretty proud of it, actually. Always room for improvements. We also have a VA in Wilkes-Barre that many of my constituents attend, and we're a very military-focused or very military-heavy district. I have Fort Indian Town Gap, so we have over 50,000 veterans within my district. Also on my district team, I have 3 veterans, Navy and Army, and 2 of which are women. So I find that to be a great benefit to the type of constituent services that we provide, as well as the work that we do for veterans, men and women. Your testimonies earlier were very compelling, very compelling. This is a very important hearing. This information is essential for us to be aware of, know better, and to respond to. That's the whole idea. It certainly sounds as if the HR departments within the VA facilities and perhaps on a more macro level need to not just be aware of this information, but take this in and create new procedures and plans around it. I think that goes without saying, and I think that's a responsibility of this committee to assure that does in fact occur. You mentioned that there wasn't much collaboration with your organization, so we need to be inclusionary by all means. The Veterans Administration as a whole, right up to the Secretary. The Secretary does need to engage. I'm sure he has, but more so. And mentioned other things from homelessness to various other issues. So do know that your words are very, very important and are resonating. So with the question I want to ask is, what is your recommendation as far as some of the things I just mentioned, what you talked earlier, what can we do within the Human Resources Department to recognize these issues, work on them on a daily basis, on a larger scale, and right down into the VA facilities themselves? So I think I will start with Ms. McCoy, if you could answer.
So I think that the big thing is going to, again, go back to language. Crafting the appropriate language to make the changes, the appropriate changes, so that the policies, the legislation, the funding, all of those are aligned in a way that they are ally support, that you're an ally, and not that the agencies are hostile. They're presenting as supportive, but in their writing and their funding and all of these other things, they're presenting as hostile. So I think that that's where we have to start. But in order to do that, you have to bring subject matter experts, women veteran, to the table, not to just talk at us, but to actually have the input from us to give the insight so that the legislation and the policies are appropriately placed and the verbiage is correct so that it doesn't exclude people like our reservists and our National Guard members.
I agree. Excellent. Ms. Ilam, could you respond as well?
Sure. I would agree that we need to make sure at the local facility level that facility director is engaged with their people, making sure they're out there watching, that the training has occurred, making sure that harassment is not occurring, that they have a way to deal with it, that they're working with employees, and that there is a way for, if it is reported, how they're going to resolve that and what they're going to do. I mean, it's got to be at the facility level. Well, you want to have a national program and you want them to push that all the way down. I mean, it's at the facility where you really need to make sure wherever a veteran might go, you don't want to see that happen. So it can't just be one program office or information coming from just one direction. It has to be across the system.
Thank you, and we look forward to working with you and for you. Madam Chairwoman, I yield back.
Thank you, Mr. Mercer. Mr. Cisnero, 5 minutes.
Thank you, Madam Chair. Thank you to all our witnesses who are here today, and I really do appreciate you coming and speaking on this matter. Care for our women veterans and the specific obstacles they face that may impact their pathways and willingness to seek out VA treatment is of utmost importance to me, being a veteran myself, especially as it relates to intimate partner violence. Director Elam, in your testimony, you mentioned some research that the VA researchers are becoming increasingly aware of the rise of women veteran patients who are survivors of intimate partner violence. And in fact, emerging research has proved that women veterans are at a greater risk for intimate partner violence than their non-veteran women. Could you elaborate on this specific research, the data that was found, and why why you think they found that data?
Well, I think one thing that VA research has really shown, I mean, they've done more research over a short period of time, like almost in a 7 or 8 year period, than they had done in 25 years. So they're really learning a lot about this population. And VA has always been forward-thinking in terms of asking questions when veterans come in. They're looking to make sure that they have the services available if someone is homeless, if someone has experienced trauma of some sort. And their findings are really, I think, showing that we need to, pay attention, be looking for these types of things. What are the specifics within this population that seem to be put veterans more at risk, that can help for prevention and can help moving forward in terms of addressing the issues? So I think researchers are on the forefront, and part of that whole aspect that really make VA unique and special, and they need to make sure that they continue that line to really be working with veterans.
And, well, now, do you have any recommendations? And, it's good that you said the VA is good out there and asking the questions, but what could they do, and what also could Congress do to kind of help along with that process to make it better?
Well, I think they need to make sure that once they've asked the question, what are the programs and services that these women veterans need to address that issue, to make sure that they have the mental health services, to make sure they have the support services around that. So turning that into action is the most critical thing. Once they've asked the question, what can we do to make sure we support this veteran?
So you raise another issue, actually, that I was going to bring up as well. It's also troubling that women veterans who have experienced intimate partner violence place them at risk for developing certain mental health conditions and substance use disorder, increasing their risk of suicide. What would you recommend are appropriate outreach programs and efforts to support women veterans that are impacted by intimate partner violence?
Well, I think some of the organizations here at the table really also have some great, an opportunity and for a really important role to play, I think, like Brigitte McCoy and others who have a support system and have an outreach that's beyond the VA arm. I mean, this is one thing that we know is often women veterans don't have they're not connected with the VA, or they're not connected with the VSO community, where they might not readily know about the resources that are available. So it's important to engage organizations that are here. This is everyone's issue, and I think that will be a critical piece in moving forward.
Does any other members have any comments of this on how we can address this issue?
So I think one of the bigger problems with related to this topic is that there will be a large group of women who will not perceive themselves as being victims of domestic violence. Having clear presentation of the awareness, being able to describe what domestic violence includes, because it's, to me, similar to military sexual trauma. There are a lot of people who say they didn't experience it until you start describing what it is and what it includes. And so that's one big part of the outreach. The other part, because WVSJ has been instrumental in connecting groups of women within certain demographics, social media, although some people think it's the devil, we've been able to, extract people from situations where it was unsafe, because we had an integrated network of peer support, online, crowdsourced, to intervene on behalf of women veterans. So there are ways to implement those things and keep the person safe and protect their identity as well.
All right, well, thank you for your answers. My time has expired.
I think today's meeting is just a terrific start for all of the issues that we need to continue to drill down on until we really do determine solutions and keep working at making that cultural change and shift that's so very, very necessary. And as I said earlier in my comments, I think this is a veteran women's Me Too moment, and I think we have to really make it into a movement. And I think that movement will help to shift a lot of the cultural issues that you all are facing as women veterans. So thank you very much, and we're going to go to our second panel. And for our second panel, we have Dr. Patricia Hayes. Dr. Hayes is the Chief Consultant for Women's Health Services at the Veteran Health Administration. Thank you, Dr. Hayes, again for having to wait for a long period of time. We appreciate you being here. And as you take your chair and get comfortable, I will recognize you for 5 minutes.
Thank you very much. Good afternoon, Chairwoman Brownlee and Congressman Musser and distinguished members of the subcommittee. I'm going to start my statement, but I have to just acknowledge the tremendous sense of being moved by the members of these veterans themselves coming here today and taking time from their lives to let us know their concerns about the VA. It's very, very important. I want to talk about the number of women veterans enrolling in VA healthcare is increasing, which places new demands on the VA healthcare system. More women are choosing VA for their healthcare than ever before, with women accounting for over 30% of the increase in veterans over the last 5 years. To address this influx, VA is strategically enhancing services and access for women veterans. Every VHA healthcare system has a full-time Women Veterans Program Manager who advocates for the needs of women veterans using that facility. VA has enhanced provision of care to women veterans by focusing on the goal of developing women's health primary care providers at every site of VA care. VA now has at least 2 women's health providers at all of VA's healthcare systems and at least 1 at 90% of the community-based outpatient clinics. VA has implemented models of care that ensure women veterans receive equitable, timely, high-quality primary health care from a single primary care provider and team, thereby decreasing fragmentation and improving quality of care for women veterans. And we've worked to implement a mobile training to specifically meet the needs of rural primary care providers and nurses at 40 CBOCs per year. VA provides a wide scope of services to women veterans, including comprehensive primary care, gynecology care, maternity care, infertility services other than in vitro fertilization, specialty care, and mental health services. Additionally, recent legislation authorizes IVF for married veterans with service-connected disabilities that result in infertility. VA has witnessed a 154% increase over the past decade in the number of women veterans accessing VA mental health care. Over 40% of women veterans who use VA have been diagnosed with at least one mental health condition, and many also struggle with multiple medical and psychosocial challenges, including trauma-related difficulties. An increased risk for suicide is of great concern. To ensure that VA mental health providers have the skills and expertise to meet women veterans' unique treatment needs, VA developed innovative clinical training such as the Women's Mental Health Mini-Residency. Unfortunately, some women veterans experience sexual assault or harassment during their military service and may struggle even years later with its after effects. VA provides free care, including outpatient, residential, and inpatient care for any mental or physical health condition related to military sexual trauma, and eligibility is expansive. Veterans do not need to have reported their experiences at the time or have any documentation that they occurred, and may be able to receive free military sexual trauma-related care even if they're not eligible for other VA care. VA is proud of its high-quality health care for women veterans. Ongoing quality measures show that women veterans are more likely to receive breast cancer and cervical cancer screening than women in private sector health care. Unlike other healthcare systems, VA analyzes quality performance measures by gender. This has been key in the reduction and elimination of gender disparities in important aspects of health screenings and chronic disease management. Since 2014, VA has tracked access by gender and identified small but persistent disparities in access for women veterans, who overall are waiting longer for appointments than male veterans. To mitigate this disparity, VA has identified sites with longest wait times for women veterans and is working with those sites directly on initiatives to improve access, including designating more women's health providers through hiring or training and improved team efficiency. VA continues to make significant strides in enhancing the language, practice, and culture of the department to be more inclusive of women veterans. My office sponsored the recently published research by Drs. Clapp and Yano that found that 1 in 4 women veterans reported experiencing harassment by other veterans when they visited VA healthcare facilities. VA is focused on ensuring all veterans are treated with dignity and respect, and women who served in our country's military deserve to be treated with honor, just as their male counterparts are. With input from male and female veterans, VA launched an end harassment program at every VA medical center in summer of 2017 and has continued to implement this program nationally. Through increased awareness, education, reporting, and accountability, VA is working to address this issue. We have launched messaging, including "It's not a compliment, it's harassment," directed primarily at educating male veterans that certain conduct is unacceptable. Employees have been trained on culture change efforts, including an awareness of the experience of women veterans and ways to intervene and respond. We will be persistent in our culture change efforts. Gains for women veterans would not have been possible without consistent congressional commitment in the form of both attention and financial resources. It is critical we continue to move forward with the current momentum and preserve the gains made thus far. Your continued support is essential to providing high-quality care for our veterans and their families. Madam Chairwoman, this concludes my testimony. I'm prepared to answer any questions.
Thank you, Dr. Hayes, and I appreciate your testimony, and I will now recognize myself for 5 minutes for questioning. The first question that I have, and I think anybody who is in the audience, I'm not sure that you can answer questions beyond the medical arena around women's health, issues like homelessness and other kinds of things, so we're not going to get into those questions. But I had recently had the opportunity to visit the VA Medical Center, which has really a very beautiful women's health center. I did mention earlier that they didn't have extended hours, but the center is absolutely beautiful. You feel like you're walking to a spa-like atmosphere. And women there can receive all of their gender-specific care, including mammograms. They don't have to leave the clinic to make that happen. And but according to a 2017 VA report, I call this the gold standard in some sense, and the standard that we all wanted to achieve. Only 7% of the VA facilities met this standard. So I'm wondering if you could speak to what VA's plans are in terms of replicating the gold standard across the country.
Certainly. Thank you for the question. We have been working for a number of years to make sure that women veterans have the right kind of care wherever they go for care. So we actually shifted away from building women's clinics for a number of years because we wanted to make sure that women out in the more rural areas and the distant areas geographically had access. That's our primary care provider, where I was saying that we're still concerned that 90% of our CBOCs have it, but 10% don't. So we've been focused very much on making sure that wherever you come for care, you have a women's health provider. In the meantime, as the population has grown exponentially, many sites have moved towards developing a women's clinic. We call it a Model 3 women's clinic, comprehensive care with GYN on site. We're now at 75 women's clinics. So we didn't say you have to do it. In fact, what we really said is that you must talk to the women veterans in your community. You must hold a town hall. You must have input from the women as to what do the women at that site want, and add in the issues about what is the best way to deliver care. And we have some sites that the women said, we do not want a standalone women's clinic. We are women, we're soldiers, where a soldier is a soldier, and we don't want that. Most sites, there's some combination of women's clinics, comprehensive women's clinics, and integrated primary care for women.
So women veterans disproportionately use community care compared to male veterans, and we know the reasons why. But how will the women veterans be uniquely impacted by the Mission Act, and how is the VA going to ensure equitable integrated care for women?
The Mission Act, of course, does allow for different kind of choice about going out, but for women veterans, about 30% of the care every year must be in the community, and that is because of maternity care, some of the infertility care, in some places mammograms, and also a lot of it is actually in-home care. As women age and live longer than men, they have more of the community care dollar. I think that what's most critical about community care is care coordination and care navigation. And we have invested in mammogram coordinators, maternity care coordinators, and really our issue is going to be making sure that we have right-sized our resources to have enough community care navigation and coordination, and that's our challenge right now.
Thank you. And there are only 65 mammogram sites in the country, and that really doesn't necessarily correspond to where there are large concentrations of women veterans. For example, Puget Sound VA system in Washington State is used by thousands of women veterans, and there's no on-site mammogram capability. So what are the standards that the VA is using to determine where mammograms should be placed?
We've recently developed a tool to continue to look at the key issues on where mammograms are, and you're absolutely correct. Most places we do not have a significant population to be able to have the highest quality of mammogram. That's critical to me, that we make sure that women are not seen by someone who hasn't seen enough mammograms. In places like Puget Sound, one of the other big issues is space, and it takes considerable space in lead-lined walls, and so we're continuing to work with sites like that about how they can prioritize adding radiology space and mammogram space. So it is about a population issue, and it is about making sure that we have the highest quality care. And the third part is navigation, and if we don't have someone who's tracking to make sure that that mammogram result gets noted by the primary care provider, gets to the breast cancer surgeons or whoever they need, we're in trouble. So we need to make sure that, number one, we're tracking mammograms, and that's the biggest part of what we're doing.
Thank you very much. My time is up, so I yield to Mr. Mercer for 5 minutes.
Thank you, Madam Chairwoman. Dr. Hayes, thank you for being with us here this afternoon. I do understand that you do some really positive work for the Veterans Administration and for women veterans, so thank you.
Thank you, sir.
I also understand that you were here during the testimony of the previous panel. Do you have any comments or response to some of the testimony given?
Certainly, thank you. I think that the issue of culture change, we really can't say enough about how that is a problem that we are focused on. We knew it was happening. We got the data to show that it was happening. We continue to, throughout the country, do more work on a wider spread of research on the topic, but it has been a challenge. Other systems don't actually have to manage this challenge of military culture bleeding over into veteran culture, and how to deal with training our employees and our veterans to end harassment. So we've worked a lot with research, but it's not good enough to say that women can just have a separate space or that they should go out to the community. We have to step up. I really like that comment about VA. It not only is stepping up, we have to step up. We have to end the harassment, not just of women, end harassment for race and ethnicity issues, for LGBT issues. We have got to change this culture. And a lot of it is engaging veteran service organizations, folks here, because part of it is what I call right-thinking men who are appalled by this behavior, and empowering them as well as they come to VA to say something to the other folks that are conducting themselves this way. So VA has this as a high agenda. I think the other thing that was really striking in hearing the panel is kind of the disconnection, whether it's a little bit of disconnection between them, but also the ongoing issue of us making sure that we are working with these partners, these women veteran expert partners, in everything that we can do, and a challenge from the level of the Center for Women Veterans and the level of every VA to make sure that we're involving these groups of women veterans and the other groups, IAVA and others that have provided information, to make sure that we're hearing them and incorporating the veterans' word in what it is that we offer to veterans. And I heard that loud and clear from them today.
Certainly. All right, thanks. What steps, as of late, has the VA taken to combat harassment when it's detected or seen at the VA facilities?
The end harassment program, and you notice I call it end harassment because we're not anti-harassment, we're not against harassment. We want it to stop, we want it to end. And we have done a number of things. We developed an education program for veterans, which it talks about this is not a compliment, this is harassment. We worked with male veterans to have them tell us, what were some of these things, because this behavior disrupts care. It's a terrible experience for veterans who experience harassment, and it just disrupts the whole system. So we have to educate male veterans. We do it in some of the new employee orientation. We are in the process, a widespread process of educating employees to understand these experiences, and also what is widely known in research as a bystander intervention, teaching them through a role-playing system how to actually intervene. And if they don't feel comfortable intervening, they can call their supervisor, they can call the police. There's a number of options. So we educate. The next step is reporting. We've set up reporting systems locally. Veterans can report, staff can report. You can report to the police, you can report to the patient advocate, and you can report to the Women Veteran Program Manager. There'll be people that are evidenced as, putting out there as you can call me, their name is on a poster. And then there's accountability. And we believe very strongly the accountability has to be at the local level. The local leadership has to be out and engaged in this. They have to know what the reports are, and they have to be actively working to change this culture, to engage the employees, to engage the veterans, to walk around and themselves say, this has to stop. We have to change this.
All right, very good. The panel also brought up the idea of an outside agency to conduct a cultural assessment of the VA or specific VAs. What's your thoughts on that?
I honestly don't know of groups that could do this for us. I mean, we work closely with some of the other major think tanks, MITRE and RAND and folks like that, and they've been involved in some of the research. I actually think that the best assessment is listening to the veterans themselves. We have what we call card studies. We've just done another round that we'll be publishing about what do veterans think about this effort. Do they notice that we're changing the effort? So I would be very interested in hearing more specifically about what someone might think we could get, what would be the utility of that. But listening to the veterans is the number one strong message that we have. I encourage facility directors to call in veterans and ask them specifically about this. What have you experienced at this VA, and where are the hot spots, where are the trouble spots?
Thank you. Thank you, Madam Chair. I yield.
Thank you, and Mr. Cisneros, you have 5 minutes.
Thank you, Madam Chairwoman. Thank you, Dr. Hayes, for being here today. I want to ask you about a specific pilot program that's being run between the Air Force Women's Health Initiative team and the VHA's Office of Women's Health Services. The program is a Women's Health Transition Assistance Training Pilot Program. As one of the previous witnesses testified, veterans aren't always aware of their services or the benefits that they have, and I will even kind of testify it was true in my own case when I was getting out of the military. Some of the data that was collected in this, for those that have gone through the program, 99% of the participants surveyed responded they would recommend this course to others. 80% of participants have agreed to post-course follow-up. Could you elaborate on some of the data findings and why is this program being so successful, and why these women have said they want to continue with this?
Absolutely. As you well know, VBA and Department of Labor and Department of Defense run a TAP program for service members as they exit the military. We knew for a long time that women veterans have been telling us that they didn't know about their benefits. And the other thing that was brought to our attention is that the year after transition, that whole transition year, is at higher risk for suicide. We're very concerned about the high suicide rate and the rising suicide rate among women veterans. And so we worked with the great partners in the Department of Defense to design a TAP program for women, which is in addition to the regular TAP program. It does walk them through their benefits at a time when women are with women, so they can talk about issues about things like reproductive health issues, gender-specific health issues. And I think that's part of why they find it a comfortable place, but it also gives them a lot more technical information about what is VA healthcare and how can they access it. They also, for most sites, we get them to a VA hospital so that they can kind of blow away the myths about what is a VA hospital like and see some of these gold standard clinics that are there and realize that they may want to enroll and use that care. This project is a proof of concept project. We are in pilot phase, and we're happy to announce that Navy just this week has very much agreed to come on board and help with Navy and Marine sites. So now we have participation in Air Force, Army, Navy, and we think that we're going to get a wider ability to have people come into it and have the various services be able to speak to what they think, what benefit it is for them. So we're going to continue to collect the data. We're going to go back to the Joint Executive Committee of DoD and VA and report our findings. And so far, people actually think it's wonderful. We're not surprised. We think it's a very important part of what we're doing. We're also going to compare it to an online version so we can see whether is it really, what's the importance of having it in person? What can you get from an online version for those that want to take it virtually?
All right. So just to be clear, it sounded like you said Army, Navy, and the Air Force are now going to implement this program?
Yes, sir.
Oh, wow, that's wonderful.
It is wonderful, yes.
Yeah. So how do we get it out of the pilot program phase and to really make sure that we implement this through the entire Department of Defense or all 3 military branches, maybe even the Coast Guard at some point there too, to make sure that we're taking care of our women veterans?
We're going to fund up the next part of the pilot, carrying us through the end of 19 now and into 2020. We need the data. It really is important, I think, when you look at something that's going to be costly in some ways, to make sure that it really is a proof of concept that this is an important addition to the TAP program. So, as I said, the next thing would be a decision. There's a well-oiled machine that works between the TAP oversight, as I said, with Department of Labor, VBA, and DoD, and it will go back to that group in their wisdom to consider it.
All right. Well, thank you very much, and I yield back my time.
Thank you, Mr. Cisneros. Ms. Roddenwagen, you have 5 minutes. Thank you for joining us.
Thank you, Madam Chairwoman. Dr. Hayes, according to DAV's written testimony, VA reports that only 70% of women veterans are assigned a designated women's health primary care provider. That's concerning, considering the improved satisfaction and quality that data indicates are correlated with such an assignment. What steps are you taking to ensure that every woman enrolled in the VA healthcare system is assigned to a designated women's health primary care provider?
Thank you for that question. We, as you've heard, are really committed to having designated women's health primary care providers. There's a national shortage of primary care providers, so we've worked a lot on training up our own providers who may have been rusty about women's health. 5,800 of them have been provided, but we found that we're still having difficulty recruiting in the remote and rural areas. And so we have established a training program that takes the training to that remote site. Our community-based outpatient clinics frequently have very few staff and can't send their staff away for a week to training. So in the last year and a half, we've actually trained up over 70 providers, and you may be relieved to hear that the first week of May and last week in April, we trained in Hawaii, and we had several folks from the islands come so they can now be designated women's health providers. We want to make sure that we reached groups that have had great difficulty in accessing this training. And you may want to interview them. I think that they were very excited to be included, and we were very happy to be able to make sure that they could get there. Lots of travel, as you well know, and it's a group that we wanted to make sure, and I'm glad you asked the question because it happened to be that we reached you. But as I said, we're looking at those sites that are geographically dispersed, that can't easily access, can't hire up. There may not be a primary care provider in that area, and we can't steal them from another, we can't steal them from Indian Health Service or another federally qualified health center. We have to make sure that we're working in partnership with all of those groups and provide the best training that we can for our women's health providers. So we still have a long way to go. We actually have such a wave of women coming in that even with all the training we're doing, this year we're going to hit over 700 trained, and we're still going to probably have a gap of 500 to 700 providers. So I'm continuing to look. Workforce management is working with me on terms of enhancing the recruitment under the Secretary's recruitment provisions and our goals for recruitment, but we have an uphill battle here.
Also, you note that provider turnout is an issue with respect to the initiatives VA is pursuing to improve training on women's health across the VA healthcare system. What, if any, incentives exist to encourage providers to seek out those training opportunities? And if none exist, what incentives do you think would be helpful?
There are not specific incentives to be a women's health provider, and that is problematic. If anything, there's a bit of a disincentive because we're getting so busy that they frequently get overpaneled quickly. They have difficulty kind of keeping everything going. We do have retention. We have turnover and retention in this group that's higher than the other primary care groups. And it's really a technical issue about there's not a separate medical certification for this group of providers, so we're not able, within the laws and rules about provider groups, we would need to have some specific way to identify the work they're doing and to be able to provide additional financial incentives in this group.
So what outcome improvements do you see for women veterans following the many residencies in women's health that your statement references?
The training itself, I think that there are both kind of subtle and really obvious things. The obvious things are resolved when you can have someone not have to go somewhere else for a pap smear because someone has been trained up on live models and feels comfortable handling a pap smear, handling a vaginal infection. The more subtle things or not so direct things are about understanding the experience of veterans in the military, trying on, what we call the battle rattle, and then going back and realizing that this complaint about musculoskeletal pain, about a headache or a neck problem or a joint problem is because of what that woman had to do with her heavy equipment on. And then we also have them trained up a lot on military sexual trauma, interpersonal violence, depression, management of basic mental health conditions in the primary care setting. So we've taken someone who is a good VA provider and helped them expand their role to really truly be a very good provider for women veterans.
Thank you, Madam Chair. I yield back.
Thank you, Ms. Rotowagen. I thank you, Dr. Hayes, for being here. And before we conclude, I just had one very quick follow-up question on the in harassment program you were speaking of. So the last thing you said about the program is accountability. And I was curious to know, when you're teaching employees around harassment, is that a required program that each and every employee must undergo like we do here in Congress? And it's, they must go through this training and must go through it on an annual basis?
Every employee must go through the employee OPM harassment program. What we're doing in VA is we are adding to that program and to several other training programs that employees are taking. There's a new program the Secretary has been rolling out called Own the Moment, and it's about customer service, it's about direct interaction with veterans, and we are enhancing that program to add this together. So to answer your question directly, that is not a mandatory program. We're still in development of how to roll this out additionally. In fact, have a meeting with the Secretary in about a week with various groups within the VA. So it's a little bit preliminary to say how much more we're going to be making sure happens. But we can get back to you on what the plans are. And not just for VHA, where we have the medical centers and the accountability, but we also want to extend the program across all of VA, the cemeteries and the benefits agencies, in terms of being able to address the culture everywhere.
So it's very possible that we have employees across the VA who've been untouched by any of these programs.
Yes, sir. Yes, ma'am. I believe that right now there are employees who have been untouched by the program.
And then you talked about the reporting system. So once an incident is reported, is every incident then investigated and pursued?
The reporting is done locally, and it's done to the patient advocate and or what's called the Disruptive Behavior Committee for Mental Health Disruption. It is accounted to the local director, and they are tracking and accounting for what is done. So because this range of behaviors can be everything from catcalling, where there might be something like looking at the design and trying to make sure that people can't congregate there and have women walk the gauntlet, that might be the action. There are many other I don't want to sort of qualify them, but egregious things that absolutely have to have police intervention. Maybe the veteran has to be accompanied every time he comes into the setting. So there's various ranges of action that are possible.
But a supervisor or a medical director or a VISN director or anybody at central office may not hear about any of these incidences.
We actually decided not to roll them up to the central office level.
So medical director level, VISN level?
Yes. I want the action to be accountable locally.
I agree, but sometimes one has to make sure that it's happening locally.
I defer to your judgment in this area. We've been going back and forth on it. I just didn't want us to create a meaningless report that people were just sending up somewhere.
Understood.
That was the issue for me, is that what's the utility in a report that just has a lot of numbers, which hopefully will go up initially. We see this challenge with these kind of reports.
Yeah.
So
I just feel like this is really, we're sort of, in terms of culture, it is sort of in a crisis situation. I think everybody, including yourself and others in the VA, acknowledge that. But it just seems to me that we need to have more tools that replicate that urgency. And so that's why I'm sort of following up on those questions. But I think our time has come to a close, and I really appreciate you being here. And I think just before we close the hearing, I just would like to say, I think what we've learned today has been extensive, and I think the conclusion is that women continue to face sexism and discrimination and inequities in the system, and a system that was originally built for men. I think everyone on the committee believes that no woman should endure sexual harassment of any kind when she's seeking her health care, and no veteran should ever have her service considered less valuable because of her gender or minority status. So I think we've got a lot of work, and the work is cut out for us, and I intend on following up and having more hearings like this one so that we can drill down further. So I appreciate everybody's participation, and with that, I will ask Mr. Mercer if he has any closing comments.
Thank you, Madam Chairwoman. No, I do not. I do, too. Thank you very much, Dr. Hayes, and our previous panelists and their testimony, so thank you very much.
So thank you again, and with that, all members will have 5 legislative days to revise and extend their remarks and include extraneous material. So without objection, the subcommittee stands adjourned. Thank you.